it's a transparent pass-through model, so we don't play the traditional games of spread pricing and keeping rebates. We don't chase rebates, so we really try to deliver a cost-effective benefit to our employers, health plan, and members. And the second way, we do a lot of initiatives around integration between medical and pharmacy. So as a PBM, we don't pay medical claims, but we do work with TPAs and health plans on aligning benefits, such as fee schedules, moving certain drugs out of the medical benefit to the pharmacy benefit if it's more cost-effective for members and the payer or the health plan or the employer group. And we also have integrated care management approach. So we actually have nurses, social workers, and pharmacists working on teams to help the patient rather than being in silos. So we actually have captured data, and we show there's a definitive return on investment with our clinical programs. And we also, in terms of the transparent pass-through model, just through repricing claims, we can deliver more cost-effective benefit. And the emphasis really over the next few years is going to be managing specialty drugs, because the projections are by 2018, the per member per year spend is going to double. So 5% of the population is driving 50% of the cost. So we can't continue to afford that. So we have to do different things to change how we deliver care. What it really is changing the model. It's putting not the healthcare team at the middle, it's putting the patient in the middle. So it's providing services, a cost-effective benefit to the patient, but it's bringing pharma, the providers, all the other stakeholders into the equation and hopefully spreading risk. Yeah, well, specialty pharmacy means a lot of different things, and so we use specialty pharmacies specifically for access to medications. But the theory and the concept behind specialty pharmacy is that they can provide a lot of services that other people don't have the resources to do. So it's compliance programs, it's education programs, but really it's also about just reducing costs because the reimbursement to the specialty pharmacy is less than it would be to a provider or to a hospital, for example. We don't exactly have the answer to that, but we have a 4 or 5 pronged approach to what we call bend the curve. So we know we're not going to stop this. There's other things that are going to have to be involved, including government and rules about meeting certain cost-effectiveness thresholds to be paid for, those kind of things. But in the interim, it's contracting, it's site of care, meaning looking at specialty pharmacy or physician's office instead of hospital, for example. It's channel management, so looking at drugs and see where they're more cost effective. Does it make sense under the medical benefit or the pharmacy benefit? So it could be moving infusible drugs to the pharmacy benefit. And then the integrated care management approach. So it's breaking down the silos that exist between pharmacy and nurses, for example, and having them work on teams and delivering a better product to our patients. One is spreading the risk. So again, bringing more people into the risk equation, and hopefully that changes how we approach things. And so we don't practice defensive medicine, we don't waste money. Hopefully we have a little bit better idea around stopping rules and things like that. And then just, again, data is going to be the other issue. So what we do has to be evidence driven. And so more and more of this is contingent on what kind of IT systems and EMRs and all the other things. And so those are the 2 big things. The success of what we do is going to be based on clinical and information technology, and if we align the incentives, then outcomes and costs should follow.